So, thank you all for tuning in, and this is the POCUS Club channel. We have some sonobites here for you today. So, this is the first round of the Stadium of Sound and Ultrasound game show that was held at EUSEM in Lisbon 2021. Now, we have Team Rest of the World comprised of Dr. Ben Smith from Chattanooga, Tennessee in the USA, and Dr. Hein Lamprecht, who is out of Stellenbosch University, South Africa. And they are going up against the team of Dr. Nikolas Sybrakis out of Heraklion, Crete in Greece, and Dr. Andy Neill from the Republic of Ireland. So I need you to comment in the comments below. Who do you think gave you the better ultrasound tips? Was it Team Rest of the World or Team Europe?
Hello, my name is Ben Smith. I'm the Director of Ultrasound in Chattanooga, Tennessee in the Eastern United States. And I have a quick rant about M-mode and the IVC. And my premise is that they should never even be mentioned in the same sentence. So let's get to it. Here's a typical looking IVC, and we like to think about looking at the IVC to estimate right atrial pressures in a patient who is spontaneously breathing. So here's kind of what you'd look at. You'd see the right atrium here on this view. IVC is right there. Hepatic vein is an important landmark. We like to measure 1 to 2 centimeters caudal towards the feet of the hepatic vein dumping in, and at that spot is where we measure the IVC. But what I see a lot of people doing is throwing an M-mode spike across the IVC and then getting this sort of view and measuring it. But I'm going to show you why this is not the right way to do it. First of all, consider this case right here. This IVC is sort of going at a 45-degree angle. And so if you are wanting to measure that IVC perpendicular to the axis of the IVC, it's nearly impossible with a typical M-mode spike. At this angle right here, we'd have to have our M-mode spike way off to the side, and most machines won't let you do this. Typically, your machine will only allow you to measure M-mode from this point right here. And what you're effectively doing is measuring this distance right here, which is larger than the actual distance that you should be measuring, the actual diameter of that IVC. So that's number one. And I can show you here using M-Modify, a free tool. I've actually generated an M-mode across this axis right here, measuring the IVC at 2.4 centimeters during expiration. And here I've measured it perpendicular to the IVC, and it measures 1.9. Clearly very different values there. And if you're not convinced there, here's just an IVC. As the IVC changes angles with respect to the probe, you can clearly see that that distance gets larger. And the last thing I want to leave you with, and this may be the most damning evidence of all, is that as a patient breathes, the IVC moves left-right. So you're actually not even measuring the same spot in the IVC. And you may say, well, I measure over here, I measure over here. It's all the same distance, right? That's actually not right. If your IVC is actually more like this, which is a sort of a saber-shaped IVC, and many IVCs look like this, you're going to be measuring a completely different thickness, and it's going to throw off your collapsibility index. So when you measure using M-mode, you're not measuring perpendicular to the IVC oftentimes, and you won't be measuring the same spot twice. So that's why you should stop using M-mode on the IVC. Thanks for your time.
Hi there, I'm Hein Lamprecht. I'm an emergency medicine physician based in Cape Town, South Africa, and I'm absolutely gutted for not being in Lisbon with you. At least we have this fantastic case that I would love to share with you. This reminded me, personally, that we should always use an inductive and deductive assessment approach while looking at ultrasound scans. This patient was very well known to us, a frequent flyer, 26-year-old male, with a one-day history of feeling feverish and unwell. He also appeared anxious. He's a known intravenous drug user, presented with slight tachycardia and tachypneic, as well as a diastolic murmur as the only clinical finding. We immediately thought infective endocarditis, and we are about to set up the treatment regime. But before we did, we had a quick squiz with the ultrasound machine. And the view that produced the highest yield was the apical four-chamber in this case, and we could actually see vegetations bouncing off the tricuspid valve. As with anything in ultrasound, we decided to be more inductive as well, and we adjusted our probe for a better focus on the area of interest. And that made all the difference. As you can see, these vegetations are not attached to the tricuspid valve, but to the intraatrial septum with a pedicle instead. This changed our management approach. We immediately thought right atrial myxoma, elective PCI was arranged, and the patient's clinical course in hospital was uneventful. Thank you for sharing this with me, and I hope you have a fantastic and enjoyable conference.
Hello, this is Nikolas from the amazing emergency medicine team of Heraklion Crete, one of the first 2 training centers of emergency medicine in Greece. I'm going to give you some tips regarding ultrasound-guided peripheral vein cannula insertion. First tip, it is very important to select the appropriate cannula for that purpose. And the main characteristic that is important to have a successful cannulation is to have a long enough cannula. This would be a cannula of a length of 45 millimeters. Tip number 2. We need to be aware of the things that can go wrong during this procedure. We have noticed that frequently, although we get a nice flashback of blood in our cannula, then the cannulation for some reasons fails. Frequently, the cannula goes too deep, piercing the posterior wall of the vein. Or the cannula is too shallow, and we get a flashback of blood, and we cannot thread in the cannula itself. Or that the distance, the course that our cannula runs in the subcutaneous tissue is too long, resulting that we manage to put the cannula in and thread the cannula inside the vein, but then there's only the tip of the cannula that remains inside. And with the first movement of our patient's arm, then the cannula stops to function. And tip number 3, we need to do the procedure under direct visualization. We have the tool, we have our ultrasound machine, and we can do that, and we will see how now. We start with a pre-procedural scan. We want to see exactly the location of the vein and its course, which will be the course that our cannula needs to follow during the insertion. Once we're happy with our pre-scan, then we prepare the skin, as we usually do with cannulas, with some chlorhexidine, and we have our cannula ready. And depending on the depth that our vein is, we insert the cannula with the appropriate angle. Generally, for superficial veins, we go almost parallel to the skin. We pierce the skin, and we wait to see the tip of our cannula. As you can see, the tip of our cannula is white, and we can clearly see that inside the vein. Now, as you can see, we already have a flashback, but we don't remove the guide, the needle. We keep it in because the tip of the needle is the only thing that is visible from the cannula with the ultrasound. And we advance the cannula while we advance our ultrasound probe simultaneously. We have inserted the whole cannula in, and the tip is still in there. And you can see it moving freely inside the vessel. This ensures that our cannula has not pierced any of the walls of the vein. And now we can let go of our probe and continue with the procedure as usually. Using this method, we have seen excellent results, successful cannulation at first pass more than 90% of the time, and this is a really important skill, especially for patients that have difficult veins, that have had multiple unpleasant experiences in the past with their cannulations. They really appreciate that skill. Thanks for watching, and many, many greetings from beautiful Crete. Bye.
Hello, my name is Andy Neill and I'm an intensive care and emergency medicine physician working in the Mater Hospital in Dublin, Ireland. I have a quick point on ultrasound and cardiac arrest. You're doing the ultrasound mid-arrest of a patient and you find this on the echo at the pulse check. CPR continues and you have to report back to the team leader. The RV is big here. Is this PE? Should we be giving lytics? But hold it right there. Dilated RV at the pulse check and cardiac arrest is not useful to diagnose PE. And why do I sound so confident, you might ask? Well, thanks to this lovely Danish study by Agard and colleagues in critical care medicine in 2017. They took pigs and they created a sophisticated cardiac arrest model and induced arrest by 3 separate mechanisms. 1 PE, 2 hypoxia, 3 arrhythmia. Then they did CPR and they took the cardiac ultrasound at the pulse check. They then took the clips, mixed them all up, gave them to some emergency docs and asked them to say what did they think the cause of the cardiac arrest was. And these guys didn't have a clue. They all had dilated RVs, and the doctors looking at the ultrasound clips could not distinguish what was the cause of the cardiac arrest. The 2021 UK ALS guidelines even have included this as a statement that we shouldn't be using dilated RV in cardiac arrest as a guide to PE. The commonest reason for the RV to be struggling is because the LV is struggling, and cardiac arrest is pretty definitive evidence of a struggling LV. So please, put the TPA away unless you have some other more compelling reasons to think that PE is the diagnosis.